co-founder of the Sleep and Insomnia Network of East Anglia. How do you pronounce the acronym?
SINEA.
SINEA. Okay, so SINEA.
The answer to most things.
So it gives you a hint of Jo's research. Her research examines sleep in daily functioning, focusing on emotional and mental health. Now, Jo is passionate, I think we can say, about bringing research to real life through public engagement, and she initiated the fabulously named, can I say, Great Parliamentary Sleep Project, and also the Great UEA University of East Anglia Sleep Survey. So I'm delighted to welcome Jo and hear about this fascinating research. Will you welcome Jo, please?
Thank you. Thank you for the kind introduction. It's been really, really nice to be here, to be hearing about your research. We're catching up with Nikki again after sort of 6 years, did we decide? Yeah. And yeah, hopefully I can tell you a little bit in the next sort of 40 minutes or so about why I care about sleep, why I think hopefully we should all care about sleep, and then what we should do about it when we move forward. So I'm going to start by giving you sort of some general information about sleep health, sort of why I care about it, what the state of it is across the world. Then I'll come specifically into my research, so sleep and emotional responding, some of the things that we found. I'll talk about a meta-analysis that took years off my life, and then I'll broaden it out again. So having sort of talked about the sleep and emotion link and sleep and mental health link, talk a bit about sort of some of the advocacy work that I've been doing over the last sort of couple of years and where I'm hoping to go in the next 4 or 5, I guess. But before I do all that, I just want to make sure everyone has the same basic understanding of what sleep is. So here are the fundamentals that you'll hear me talking about sort of throughout the talk. So when we go to sleep, it's not just a uniform thing. We don't just go into a black box, power down and power up again in 8 hours' time. We go through these cycles. So we start in very light sleep in N1. If you wake up from N1, you probably won't feel like you've been asleep. You go into slightly deeper sleep, so N is non-REM, stage 2, and then into deep sleep, which is non-REM, stage 3, and you'll also hear non-REM 3 called slow wave sleep. And then the other type of sleep that we have is rapid eye movement sleep, so that's typically when you dream, tends to happen a bit later in the night, and so the night in general is split to non-REM and REM, and then, like I say, 1, 2 and 3, and we go through these sort of 90-minute cycles through the night. So we start off going quite deeply into slow wave sleep, and then we'll come back out. We might get a little bit of REM, we'll go back into deep sleep, and then as the night progresses, we've hit our requirement of slow wave sleep, that drops out, and our REM sleep starts to kind of increase as the night sort of progresses. So we think that these different things, different stages of sleep do different things for our health and well-being. And I'm going to throw a question to you now. So how many of us got at least 7 hours sleep last night? Oh, I'm impressed. At least 6? 5? I don't practice what I teach. 4? Yeah, I'm not doing this to shame anybody, especially not, research is research and all that. But what we do know is across the world, sleep is truncated quite regularly for individuals. So there's quite a few different studies. The BASH study is actually an adolescent study. It was run in America over several thousand individuals, and they found that it's a scary amount. I think about 30% of teenagers were getting less than 6 hours sleep a night regularly. And we know that at that stage, for teenagers, you want normally about 8 to 10, and at 6 or less, you're starting to see these really deleterious sort of daytime consequences. The Welsh study was an adult study. It was done with smartphone data, and they also found sort of fairly robust evidence across thousands of people that we're not getting as much sleep as the professionals would like us to get. And then most recently, Scott used an under mattress study. So it's like a little inflatable mattress that sits under your regular mattress, and then it can estimate how long you're asleep and you're awake for. And they found about 30% of people were not getting between sort of 7 and 9 hours sleep per night. But then they also found that even when people were getting on average that amount of sleep, only 15% of people were regularly getting that at least 5 nights per week. So a lot of people, even when they're on average getting about the right amount of sleep, what we're finding is they're short on some days, longer on others, for example. And so on weeknights, we have about 2/3 of adults, and on weekends, sort of 3/4 that are sleeping in this idealised range. And so there's some caveats to these studies. Obviously, you have people who decided they want to put a sleep mattress and measure it. So you may well be getting people who are worried about their sleep in some way, shape or form anyway. But I think what we're seeing time and time again from these sort of epidemiological studies is that people are not sleeping for as long as sleep experts would like them to sleep for. But should we care? Like, is this just a kind of gold standard that me as a sleep researcher thinks, well, actually, of course you should sleep for 7 hours a night. Like, does it actually matter? Hopefully by the end of this talk, we'll sort of agree that perhaps it does. So in the UK, we have something called the Sainsbury's Living Well Index, and that is where they rate a whole bunch of different things. So your support, your income, your health, the health of the people you care about, how lonely you are, a whole bunch of different factors. And then they stack them together to see, well, what predicts people saying that they live well and what predicts kind of distress. And sleep was the single biggest predictor of living well. So to put it into perspective, it rated 4 times higher than having a good amount of disposable income. It was higher than like people being lonely, being happy with your sex life, feeling like you're connected with your neighbours and the people around you. And then when you looked at it from the point of view of not having good sleep, so it being a sort of deleterious effect, it was in the top 3, along with, I think, kind of worrying and poor mental health. And I've forgotten the third one. But either way, it sort of seems to have this, but the general public feel, a very strong effect, certainly in Britain. And across the world, again, there's been lots of studies that have been shown that if you follow people up over long periods of time, you control for health statuses, you control for well-being, demographics, other things, income, for example. If sleep is poor, you tend to see an increased risk of mortality. And rather than sort of depressive, and I don't just mean one poor night's sleep, I mean persistently over weeks, months and years, these poor sleep can be associated with increased all-cause mortality, so accidents, things like that, increased cancers, increased diabetes, increased mental health risks. So it's a fairly bleak picture. And there's also quite a big economic burden that comes with this. So I don't think we often think about this, but Hafner did this study, they modelled it, and they found, I think in the UK, they think poor sleep costs about 1.3% of our GDP. So that's about $50 billion a year. In Germany, it's about $60 billion. In the US, it's about $400 billion a year. And they model that through things like sickness rates, through increased illness, but also things like presenteeism, so being at work and just sort of being a bit like vacant and not really quite sure what's going on. And so there's a financial cost, there's a cost to our life, there's the fogginess, right? Like you don't sleep so well, you can't concentrate quite so well. You have someone at the front of the lecture theatre talking about sleep and it feels like a subliminal message and you're trying really hard to keep yourself awake for the next half an hour until you can have some coffee. But you have that impaired cognition, you have foggy memory, you have, I think, poorer mental health and poorer emotional health. And that's what I'm going to sort of zoom in on now when we come to sort of my work a little bit more. And I think anyone who works in mental health services, I think will probably feel that hopefully that this rings true, but sleep seems to be a transdiagnostic feature of almost any mental health condition. So whether it's people feel very depressed and then actually are sleeping more, or they have insomnia, people are worrying and it's keeping them up at night, people have post-traumatic stress and they have nightmares. It's there across sort of the spectrum. It's also present in a lot of people who have neurodiversity, whether that be ADHD, whether that be autism as well. And to give you a few examples, so people who experience stress and anxiety often have longer sleep onset latency, so it takes them longer to get to sleep at night, and that makes sense, right? You lie in bed and you're tossing and turning and you're worrying, and less total sleep time overall. There's also been some fun experimental studies done. So, for example, people will come into the lab and then be told, surprise, you're doing karaoke today, and we're videoing you, and you're going to watch it back. And once you do that, turns out afterwards, if you then measure people's sleep, they spend less time in REM, they spend less time in slow wave sleep, they wake up more during the night, and so their overall sleep efficiency, the amount of time that they spend asleep compared to the time in bed, is impaired. And so if you make people stressed, they don't sleep as well. And so hopefully this is chiming with your kind of lived experience, your day-to-day life as well. And so having sort of thought a little bit then about those sort of two things, so we know that in people who have mental health problems, sleep seems to be a disruptive feature of that, but we also know that quite often if you don't treat the sleep problems, they persist even when other symptoms remit. So it seems to be that they're predictive, potentially of relapse down the line, and often they can precede mental health problems emerging. So some of the studies that have been done in young children have shown that disrupted sleep when you're sort of 6 or 7, persistently over time, can lead to increased instances of anxiety, depression, substance misuse, self-harm, sort of in the teenage years and into the early 20s. And that's even after you account for those symptoms at age 6 or 7 and account for parental mental health status and a lot of these other sort of predictive factors. So sleep seems to be having some kind of causal impact as well. And so I think it's worth thinking about, well, lots of questions, but at least 3 that I'm going to talk a little bit about today. So 1, what happens to our mood when we have poor sleep? So how do we feel emotionally? And then how does sleep impact what we do about how we feel? So our emotion regulation. And then how do those things together combined potentially influence our mental health? And so to start with some of these, I'm going to talk about a meta-analysis that came out a couple of years ago now. And this was something that we first dreamt up, myself and Cara Palmer, when we were both postdocs at the University of Houston. And we sat in our office together and we were like, do you know, there's not been a meta-analysis done in this since 1996. And the 1996 one did cognition and everything. And like, it'd be a really good way of like getting to know the literature. How bad can it be? Spoiler alert, it took 6 years. And so we thought, oh, well, anxiety, depression, we'll have those as well. Positive mood, negative mood, right, we'll look at lots of different types. We've got to look at lots of different types of sleep loss. And pivotal moment, our supervisor said to us, well, is my role to rein you in? And we were like, yeah, maybe. And then she went ominously quiet. But anyway, what we did was we looked at 3 different types of sleep loss. So we looked at total sleep deprivation. So you wake up one morning, you don't go to bed for 1, 2, 3 days later, and then you look at how mood changes over that period of time. So that's complete sleep deprivation. Then we also looked at sleep loss. So people got some sleep, but not the amount that we would like them to get. So maybe they slept for 4 hours a night, 6 hours a night, whatever that might be. Or we looked at sleep fragmentation. So fragmentation is not so much that you're not getting enough sleep, it's that it's disjointed. So it's a study, for example, where you just wake people up when they hit slow wave sleep, or you just wake people up when they hit REM, or you wake them up periodically every 20 minutes because it's fun, or and it's those sorts of things that often mimic things like new parents who wake up regularly to breastfeed their child because their child's awake, people who get woken up by car alarms or noisy neighbours or things like that. So often it's not necessarily that people aren't just getting enough sleep, it's also that the sleep they're getting is broken. So we looked at that as well, and studies looking at that. We wanted to look at, well, is there a dose effect? So does how long you're awake for or how much you've slept affect these emotional outcomes? Does it matter which sleep stage you disrupt? And do things like age and gender make an effect, or age and sex in this case, make an effect on our outcomes? So we screened over 15,000 initial abstracts, and we ended up with 154 studies from over 100 papers in there. And we looked at lots of different emotional outcomes as well. So we looked at positive mood, so feeling energised, enjoyed, interested, calm. We looked at negative affect or negative mood, so being grumpy, tired, irritable, unhappy. And then there were a lot of studies that had bipolar mood scales. So they went from rate from sad to happy, or rate from calm to anxious. And so you couldn't unpick from that, is it that somebody is feeling more positive, or is it that they're feeling less negative? And so that was just a kind of generalised mood disturbance that sort of came in. And then, unlike other meta-analyses that have done this as well, we also took anxiety and depression and did them separately. And the reason we did that is because we think that there's also kind of physical things that happen with anxiety and depression. A lot of the depression scales actually ask about sleep as part of it, so there's a confounder there. And so we didn't want those kind of contributing to the general negative affect. We wanted to see whether there was something different about anxiety and depression specifically. And then all of those things so far are thinking about our general state of mood, right? Like you wake up, how happy are you feeling? But it's also, I think, important to think about what happens to our emotion in response to when something happens, so some kind of stimuli. And so there's also, we included reactivity studies. And the most common of these are things like, we'll show you an image or a video, and then we'll say, how are you feeling in terms of like how happy or sad, or how positive or negative, and then also in terms of how aroused or calm you're feeling. So you get these two different dimensions. And it's just important, like, methodologically to note that some studies will ask about the image and will say, if you see this image, how happy is this image, or how scary is this image? And that's a kind of emotional perception task. So we're not so much interested in that, we're interested in elicitations. We're interested in, how does that image make you feel? And so if it explicitly said that it was about emotional perception, we excluded it, but otherwise we included it in, and we sort of looked at this emotional elicitation. So overall, this meta-analysis had about 5,500 people, had 1,300 effect sizes, and 19 overall different analyses, so one for each of these, and then the 3 different types of sleep loss as well. So what did we find? Well, in line with a lot of the literature, we found that sleep has a much bigger impact on our positive feelings than it does on our negative feelings. So we are much more likely to report feeling less happy, less excited, less sociable than we are to report feeling more irritable or more angry or more aggressive. And that's something that's a fairly robust finding through the literature. So it was a good sanity check that we were on the right place. But what was new in ours was that we found that not just in full sleep deprivation, but we found it in sleep restriction, and we found it in sleep fragmentation. So it doesn't seem to matter how your sleep is disturbed. Once it's disturbed, you tend to feel less positive. And I think the other thing to sort of talk about the dose response in relation to this, it seems to happen quite quickly as well. So you see quite a quick reduction in positive mood, and then it sort of flattens. And so, and I think if you think evolutionarily, potentially that makes sense, right? So if you think about theories of positive emotion, a lot of them are about this idea of like broaden and build, like having social curiosity, going and finding creativity, having new things. And if you're tired, we also know that from your cognition that you don't make as good decisions, like you're not as good at assessing risk, you're not as good at reading social interactions, so perhaps it's quite protective when we're tired to stop us doing those sorts of things. And one of the kind of methodological limitations of literature out there so far is often when we talk about positive emotion, we're only talking about the high energy ones. So it's quite rare to see sleep loss measured in response to feeling calm or feeling content or feeling those sort of low energy positive emotions measured in response to sleep loss. And that's a bit of a gap so far. My hunch is that probably those would be more preserved. We also found, in line with the literature, that you see some effect on negative emotions, but they're much smaller. And they're much less consistent. So you see a sort of small effect of total deprivation, or medium, a small effect, and then a non-significant effect of sleep fragmentation. General mood sort of sat somewhere in the middle, which would make sense if it's a mix of the two. Anxiety was the second biggest after positive mood, so again we did see people like a moderate size increase in anxiety. And depression, we saw a catch-all, so it wasn't actually a significant result because you can see we've got huge error bars. And we think, although we only included studies that had healthy participants, there is a well-known effect in depression where potentially for some people, if you have depression and you're sleep restricted, you actually see a mood uplift. And it's sort of counterintuitive to what you see for a lot of people who are healthy who don't have depression. And although we only looked at healthy populations, we can't necessarily rule out that people either weren't screened for depression in the study or that they were perhaps remitted depressed and so perhaps were still having these uplifts or were undiagnosed depressed people. So we think that's perhaps messing the waters there for that. So that's a lot of data that I've given you very quickly. I guess the take-home points were the effects were strongest on positive emotions, and that was most robust across all forms of sleep loss. The negative effects were small and less consistent, and that was different. There was a meta-analysis that came out 2 or 3 years before ours, and they did find bigger effects, but they put anxiety and depression in with negative affect, and we think that perhaps anxiety was driving sort of some of those effects, whereas we separated them out. And like I said, the effects on depression was inconsistent, possibly due to the types of, like I said, this mood uplift, but then also a lot of, like I said, a lot of depression scales will have an item about sleep disturbance as a symptom of depression. And we did rate our studies on quality, but some used depression measures that didn't include sleep, others used the ones that did but just took the item out, others didn't even do that. And so we think there's sort of some compound and some measurement bias that's sort of there in the field as well. So having done a super quick whistle-stop tour of what sleep does to our emotions, I guess the next question for us then is, well, what does it do to how we control our emotions? And so Tommaso, this was the other meta-analysis that came out a couple of years before ours, looked at this, whereas we didn't. And at the time, experimentally, there was only, I think, about 12 studies overall, or 8, in fact, I put them here. And most of those studies at the time, experimentally, were done in children and adolescents. And so, again, the study methodology would be that they would encourage parents to bring in their child where we would then, or the people in the studies would then sleep deprive them. I don't know how they got people to do this, but I know these children would come in and then there would be either school teacher reports or parent reports or child reports around things like how easy it was to children to become more relaxed, or when my child's angry, it's easy for them to kind of bring themselves back down, or a child would say, it's easy for me to think about something different when I'm frustrated. And then when we think about emotion regulation, we tend to think about some strategies are quite adaptive. So some strategies like problem solving, for example, or communicating with friends, or so seeking social support, distraction, they can be quite positive strategies that we know can be quite beneficial to our emotions. And then there's other things that people do routinely that actually aren't quite as effective. So just like suppressing, hoping it'll go away, like shutting your eyes to it and hoping it'll go away, or that kind of ruminative, why does this always happen to me? Why do I always forget my words just at the point when I want to speak about something? Why, did that person really think I looked really stupid this morning when I got breakfast, or whatever it might be? And those types of effects tend to be ones that aren't so helpful for us when we're managing our emotions. And the sort of upshot of this meta-analysis was that sleep loss had a small effect on adaptive regulation, so we were slightly less good at doing things that are going to be helpful to managing our emotions, but it didn't really have any difference when we thought about sort of the maladaptive strategies. And I think there's just a couple of caveats that I want to give, not about this meta-analysis, they did a great job with that, but about the state of the field in general. And that is that a lot of times when sleep researchers talk about emotion, they'll talk about emotion regulation, but what they mean is they'll say like, oh, people have low moods, so emotion regulation is impaired. So they talk about the outcome, but then they're inferring the process. So the emotion regulation is actually a process, it's what you do. And then the other issue is, even in some of the measures of emotion regulation, where it sort of says, oh, it's easy to redirect my child, for example, or it's easy for my child to calm down when they've been angry, we still don't know what they're doing to calm themselves down. And again, that would be a kind of emotion regulation strategy. And so that brings me sort of to my next study. The cross-sectional study that I did, again with Cara, in America a few years ago now, was we looked at the national comorbidity sample, adolescent sample, so secondary data of about 10,000 adolescents. And it had in there some sleep problems, so like initiation insomnia, so it took me a long time to get to sleep, like sleep maintenance insomnia, it's difficult for me to stay asleep, or I wake up too early in the morning, so early morning insomnia. So it had these 3 different insomnia questions, and then it also had asks about whether people have been diagnosed with a range of different anxiety disorders and a range of different mood disorders, so panic disorder, specific phobia, generalised anxiety, social anxiety, depression, bipolar disorder, for example. But it also had a series of single item questions about different emotion regulation strategies, so we pulled those out as well. And so we had things like sort of avoiding things and hoping it'll go away, suppressing, I just don't want to think about it, ruminating, so worrying over and over, reappraisal is thinking about something different and hoping that it'll just make everything feel better, problem solving, so actively trying to do something to change your situation, and then accepting how things are and how things go. And what we found was that if we ran this as a mediation analysis, that sure enough, people who had more sleep problems reported higher levels of anxiety and higher levels of depression. That's fairly well known, we're not going to get published with that. But what we also found was that people who had more sleep problems reported using suppression more, reported using rumination more, and using problem solving less. And then those people who did that also then, so more suppression, more rumination, more anxiety, more rumination, less problem solving, more depression. And we found that there was this kind of explanatory mediation that was conducted that showed that these different emotion regulation did seem to have at least some explanatory power over this relationship between sleep problems, anxiety, and depression. Huge caveat here that it is cross-sectional, and absolutely, I reckon you could probably run these the other way around as well. So I'm more anxious, so I ruminate more, and it makes it more difficult for me to go to sleep. And I don't think anybody would argue that this is not a two-way relationship. But in terms of our kind of thinking about sort of sleep underlying mental health problems, we thought potentially this gives us a really nice sort of target for intervention at 2 different points. So we can intervene at the sleep problem stage, or we can intervene at the emotion regulation stage, hopefully both with the outcome of improving mental health. And so I think, again, I feel like I'm not doing anything justice here. I'm going through everything very, very quickly, but I think there's several different mechanisms that can help us explain what the association is between poor sleep and worse mental health outcomes. So our first one is, well, actually, our emotional reactivity changes. I didn't really talk about that in the meta-analysis, but you do get this blunting. So we don't necessarily feel less positive or more negative, but our level of arousal is much less. So we just care less, right? We're just too tired to care. And we do see this sort of general overall lowering of positive mood. And then when we think about how we consciously modulate emotional responses, our emotion regulation, that also seems to change in relation to our sleep loss. So we're not as good at doing those adaptive emotion regulation strategies. And the people who don't sleep as well potentially also don't have as positive emotion regulation, and then that can lead to these different effects as well. I've not talked today at all about the neurological changes, but they are there as well. So by all means, if you're interested in this, come and grab me at lunchtime or what have you. We can talk about how the amygdala and the limbic system respond to having poor sleep, and newsflash, it's not great. So I guess then, having thought about that, I guess my next link is to go, okay, if I'm telling you that sleep has this impact on mental health, if we improve sleep, do we see downstream improvements in mental health? And so I've got a colleague at the SINEA network, a lady called Rebecca Rollinson, who does a lot of work looking at CBT for insomnia and how that sits in a youth mental health setting and how it can be used by people while they're on the waiting list for kind of other treatments. And she's had some really positive results. And that sits into kind of wider literature that finds similar things. So cognitive behavioural therapy for insomnia, or CBTI, is the most widely evidenced treatment that's not drug-based. And it's the one, again, in the UK that is NHS recommended, although provision is very patchy. And we know that it reduces how long it takes you to fall asleep, the sleep onset latency. It reduces how many times you wake up after you go to sleep, and it improves people's perceived level of sleep quality. But we also know from evidence that CBTI, and only just doing the CBTI intervention, can reduce anxiety. It reduces experiences of paranoia and hallucinations in kind of like psychosis departments. And then there's mixed evidence on depression again. So depression does seem to be this bit of an outlier that seems to do something different in relation to sleep. But overall, I think there's certainly tentative to positive evidence that suggests that if you target sleep with sleep interventions, you see these downstream mental health effects as well. And that brings me nicely, I think, to the last sort of 5-10 minutes of my talk, where I sort of come into thinking about, like, well, okay, we know all of these things, so what do we do about it? Like, how can we advocate for better sleep? And I've got two projects, well, I've got several, but two projects I'm going to talk about at the moment that are kind of on the go as we speak. And the first one is thinking about sleep in healthcare courses, so for healthcare practitioners. And this came around anecdotally originally. Like, I give quite a lot of public talks in the UK, and often I'll have a medic come up to me at the end and they'll say some variant of, well, yeah, I get my patients all the time telling me I can't sleep very well, but I don't have that much training in sleep. And unlike other lifestyle things, I haven't got anywhere I can send them. There's not a dietitian for, like, you know, nutrition-related issues or physiotherapy or, you know, pain management. They're like, we don't have a sleep service in the same way. So what do you want me to do? Okay, it's a fair point. And then the American Academy of Sleep Medicine, I'm not going to ask you to read all this, has a position statement. I've put it there. You're welcome to these slides if they're useful to anybody. And essentially what it says is, well, you have all of these different multifaceted connections. So it's really important to teach people about sleep, whether that's in primary school, secondary school, university, whether it's healthcare professionals, but also we should be thinking about sleep in our healthcare environments. We should be optimising conditions to help people sleep. We should be thinking about how the drugs we give people impact on people's sleep, and we should be trying to train people so they understand how to, like, make it as easy as possible for people to sleep as well as possible. And so, again, sounds sensible to me, but, you know, an American Academy of Sleep Medicine isn't going to say, sleep's not very important. So why do I think we should look at it? Well, it's a fundamental biological process. It intersects with all of our different body systems. Sleep problems are incredibly common. I think about a third of people will experience some form of insomnia at some point in their lifetime. And then when you start to think about other health problems, the prevalence of sleep problems goes up absolutely dramatically. And so it can often precede or exacerbate other conditions. Our medical interventions, whether that's being in hospital and being woken up at 2 a.m. to have your blood pressure taken, or whether it's the types of drugs that we're being given or other interventions, can have an impact on our sleep. But also, when we think about sleep and circadian science, that can help optimise the effects of things like drugs as well. So a lot of things like blood pressure medications, other medications, if you take them at different times of day, will have a different impact based on your natural rhythm of things like body temperature, blood pressure, those sorts of things. So understanding that can also help us make other medicines more effective. And then we've also, if we think about it, a lot of our healthcare providers are sleep deprived, right? They do shift work, they have highly stressful jobs, and so encouraging them to understand and look after their sleep can also then help make a better environment for patients and make the decisions they make better as well. And then fundamentally, having these different sleep interventions, I think, can have wide effect, different transdiagnostic effects. So, what did I do about it? I have a habit of proposing research that sends my head of school slightly wide-eyed, and this was one of them. When I went to him, I was like, I'm going to send a Freedom of Information request to every university in the country. And he went, okay, why? And so what I did was I said, okay, these are the different healthcare related courses, so nursing, medicine, OT, physio, speech and language therapy, dietetics, clinical psychology, the other sort of clinical professions. And there was 122 universities, 1,100 courses, and I was I'm just going to ask them if they teach about sleep on it, and if they do, what do they teach, and like how long is it assessed, that sort of thing. And we included anyone where at the end of the course they're going to be kind of a healthcare provider, in so they're HCPC registered or they're registered with the practice of midwifery or what have you. And we excluded people where they're not likely to come across people who are going to ask them about sleep, so chiropodists, dentists, X-ray technicians. So we had quite a wide range. I'm just getting the data in at the moment. And the aim was to map the quantity and scope of provision. So is the things that we're hearing anecdotally actually true? Like, are people getting trained? Where are they getting trained? What are they getting trained in? We asked them about client and patient sleep, we asked them about practitioner sleep, and we asked them about like different topics and things like that. And we're just in the process of getting data back. So it's been really exciting. We've had over 90 universities who have actually given us the information that we've asked for. You are allowed to turn down FOI requests. You're allowed to turn them down if you think it's going to take too long to collect the information. So some people have turned them down on that basis. A couple of people turned it down at being commercially sensitive. My personal favourite is you can also turn it down if you consider it to be malicious or vexatious. And one university told me that it was a vexatious request that had no public interest and was clearly only to further my own commercial benefits. So I assume they don't teach about sleep. Anyway, so what are we going to do with all of this? Well, we're going to hopefully put it into a position statement. So I'm working with the British Sleep Society on it. I'm working with some other people, so to try and map out, okay, well, OT seems to do sleep really well, or clinical psychology are really good at sleep, or medicine cover it but only cover this. So we know what's being covered where, but then we can use it as a lobbying and sort of position statement to go to these different governing bodies and say, look, it's important, but it comes with some limitations, right? We already know that most curriculums are overcrowded, so to get people to talk about sleep, they're going to have to take something out, or where's it going to fit? And so it also means we can start thinking about like lobbying government and thinking about like the funders and being like, okay, well maybe the answer then is to have better sleep-related provision pathway. So the very last thing I'm going to talk about, and then I won't stand between you and your coffee any longer, is our final study, our Great Parliamentary Sleep Survey. So we did this partly as a research project, but more as an advocacy project, where we came together with colleagues at University of Oxford, at the nightclub charity, and we had some help from a lobbying company as well. And we asked MP, and this was the second project that my head of school got a bit wide-eyed over. I went to him and I was like, we're going to ask everyone in the House of Commons how they sleep, and then we're going to report it, and we're going to ask the media to cover it. My press office had a field day with that. But anyway, we got responses from 142 people, and about 50% were Lords and MPs, and about 50% were staffers. And it was a really short 5-minute survey, so it had some stuff on sleep health, it had a couple of insomnia questions, and the results aren't earth-shattering, right? About a third of people were rarely satisfied. Nearly 80% of people only rarely or sometimes slept for the amount of sleep that we'd like them to. 45% of people reported having sleep problems. And if you think about the environment, that's probably not that surprising. But what it did mean was it meant that we could go back, we could do an afternoon tea in the House of Commons, and we could say, look, even among your own colleagues, this is something that's important. And given that this is something that's important, what do you think we're going to do about it? Like, can you, for example, this was a shift work event, put in a minister that's responsible for shift workers and advocate for their health rights, including their sleep? Can you think about proper funding for sleep-related medicine and that kind of thing? And just sort of start to plant the seeds, and hopefully we can then sort of water that over the next few years and see sort of benefits down the line in our kind of medical and healthcare things in relation to sleep. So thank you. I've realised I've thrown an awful lot at you in sort of 45 minutes, and I'm out of breath, so I think I probably talk quite fast. But hopefully what you've gained from this is that what I'm really passionate about is raising awareness sort of locally, nationally, internationally about why good sleep is important, and highlight that, again, it's not, a bit like you were saying with gender and resilience, it's not just an individual person's problem, it's also something that we can think about as a society about what makes good sleep and what we can do to promote that at institutional levels. Advocate for better sleep-related programmes, and I guess that Bill Demont was one of our founding fathers of sleep research, and he said, well, you're not healthy unless your sleep is healthy, and I guess as a field what I'm hoping that we'll do is try to improve access to healthy sleep, I guess, across the board. So, thank you. Yes, that's a really interesting question. So, I don't know if everyone heard, but do you just divide by life stage? So we only included people from 7 and up so that we didn't have to worry about that kind of early confound with napping, and we could just look at the nighttime sleep stage, because I think in like toddler studies, given that some children like lose their naps at different stages and things like that, trying to work out like if you put a nap in for a toddler, is that healthy sleep or is it sleep extension, or if they don't have a nap, is that restriction? So that's a separate meta-analysis we didn't look at, but we did we looked at people from sort of 7 to older adults, and we did look at like lifespan sort of moderators. There was definitely an effect of age, but only on some things. I think it was on the emotional reactivity. We saw an age effect. In terms of, I think, younger people, it was more pronounced than older people. And I think there was less of an effect than you might think. And then looking at some of the population studies from earlier, that was just an adult-based study, but actually that was flipped in reverse. And so normally we would expect sort of 18 to 25-year-olds to have worse sleep than, say, 40 to 50-year-olds. But in this big population study, had, I think, 11 million nights of data, something like that, 67,000 people. Actually, it was sort of 41 to 50-year-olds that were sleeping worse, or 41 to 65-year-olds, which again I think might be a recruitment issue, but also goes to show that I think you're not immune to poor sleep across the lifespan, it's just perhaps what's affecting it is slightly different. There's huge variability, and I think that's really important. So it's a bit like if you turn around and said everyone's average shoe, like the average shoe size is a size 7, everyone has size 7 feet, you'd be laughed at, right? Because it's ridiculous. Of course you don't. And there is, some people will feel like they'll function quite like they'll have a natural point where they wake up in the morning, they feel refreshed, and that is probably your best indicator that you're getting enough sleep. And for some people that might be 6.5 hours, for some people it might be 9.5 hours, and so you have that natural variability, definitely. Slight caveat I would give is that studies that look at sleep and metacognition, so how good you are at judging your own abilities, show that the less sleep you get, the more impaired your judgment is. So it's a bit like alcohol, right? You can have a few drinks, or you can have a whole night of sleep loss and be absolutely convinced that you're absolutely fine, but then your reaction times have slowed down, or you are missing things in your peripheral and things like that. So I think the caveat is that you can be affected even when you don't realise it. But I guess 2 important points. One, yes, there is huge individual variability. And I guess the second thing is, I think as researchers, we have a a responsibility, I guess, to also not terrify the people that are doing everything they can but are not sleeping very well. Because if you're not sleeping very well, you already know that it's important to you. You're already trying to do everything you can, and actually having someone tell you, oh, are you prioritising? That's important, is not helpful. And so I think there's also that balance, like I say, the odd night of not sleeping well, or choosing to prioritise going to a gig, or staying up late to finish your presentation slides, or whatever it might be, not going to be a problem. It's day in, day out sleep restriction, where you're waking up feeling kind of deprived, you're waking up feeling groggy. Those are the times where actually it's worth kind of trying to problem solve it if it is an issue.